So in the interest of time, we'll get started with our webinar. And welcome to today's session titled Budgeting for Integrated TB Programs within the Current Funding Landscape. This workshop is part of the Union
Sorry,
CC
we cannot hear you.
Oh, no?
Now, yes.
Okay. Testing, 1, 2, 3. Please let me know if you cannot hear me. I'm getting thumbs up. Okay. Let's go again. So as I was saying, this workshop is part of the Union CDC Sub-Saharan Africa Regional Child and Adolescent TB Center of Excellence ongoing series to support member countries in preparing and prioritizing global funding requests. As we know, countries are currently facing a constrained funding environment while required to optimize available resources. There is a strong push towards integrated service delivery. However, translating integration into budgets remains a challenge. In this session, we'll provide practical insights on how to cost integrated interventions and align budgets with programmatic priorities to bridge the gap between program design and financial planning for impact and efficiency.
Sorry, Walile still disappeared. The audio embedded, yeah.
Okay.
It may be on your side, because I can hear her fine.
Is that only
it hasn't
me?
dropped. It didn't drop
I
once
can hear
on my
Willie
side.
fine as well.
Yeah, it may be your internet.
Demilesh, because you're one of our speakers and we really would love to hear you clearly when you present.
I think my internet is good. Yeah, I can hear you also, but in between just disappeared. That's why, sorry.
Oh.
Yeah.
Okay.
Now I can hear you very well.
Okay. Well, let's hope it stays like this because we really would love to hear your presentation in full. So we have three main objectives for today's webinar, which are to strengthen country capacity in budgeting for TB programs within an integrated service delivery framework, to provide practical guidance on costing, quantification, and resource allocation, and to support countries in developing realistic and fundable global fund proposals. As such, we would like to welcome our esteemed speakers and facilitators, representatives from our COE member countries, colleagues from the Global Fund, and partners from CDC and other partners. And it is now my pleasure to introduce our session facilitators who will guide today's discussion and reflections. We have Dr. Peter George Nima, who is a Tanzanian public health specialist, serving with the Ministry of Health as the NTLP Program Officer and Pediatric and Adolescent TB Coordinator. He has experience with Global Fund compliance budgets and funding proposals, write-up, and implementation. Our second facilitator is Dr. Alan Kachuka, who is a public health physician serving as Pediatric TB Coordinator in Zambia's National TB and Leprosy Program. Dr. Kachuka has extensive experience in program implementation, capacity building, and operational support, including strengthening childhood TB services and integrating child and adolescent TB priorities, international planning, and Global Fund supported programs. We look forward to an interactive session with you all, and over to you, Dr. Kachuka.
Thank you so much, Dr. Welile, and greetings to everyone who has joined in for today's session. So just confirm if you can just hear me clearly as well.
Yes, we can hear you.
Thank you so much. Our first presenter for today is Ms. Lindiwe Zwane Chechad, who will share an overview of budgeting and global fund proposals. Ms. Lindiwe is a senior manager, team leader, and public health and M&D expert at PricewaterhouseCoopers in Eswatini, with 15 years of experience supporting health programs across Southern Africa. She leads local fund agent assurance and technical services for Global Fund HIV, TB, and malaria grants, working closely with governments, implementing partners, and Global Fund country teams across multiple countries. Her expertise spans the full grant lifecycle, including funding request reviews, budgeting and reprogramming, performance assessments, and value for money analysis. With advanced qualifications in public health and development economics, she brings a strong ability to align epidemiological evidence with programmatic priorities and realistic budgeting, particularly in integrated TB, HIV, and health systems programs. She is also a certified auditor and has contributed to major evaluations and financial reviews for global donors such as Global Fund, USAID, and UNICEF. She is widely recognized for translating complex data and financial information into clear, actionable insights that support effective decision-making in resource-constrained settings. We are very pleased to have her with us today to share practical insights with her experience working with multiple countries across the region. Ms. Lindiwe, over to you.
Thank you so much. That's a lovely warm welcome. Thank you for everyone for having me. It's delightful to be here, and I hope I can be useful and relevant to you all. I'm just going to pop up my slide, and you will let me know if you can see my presentation. You can hear me okay as well? Can you hear me? You good? Great.
Yes, we can hear you.
Excellent. So yes, I am delighted to come and speak to you all. I wanted to start the session about why budgeting matters and why sharing this feedback and things that I've seen in my experience in receiving the final budgets I think will be useful to you as you begin the development of the GC8 funding requests, or in some instances program continuation, and where your roles are absolutely critical. So I think Welile has correctly said it. The GC8 allocations are smaller and they are more competitive. Integration is encouraged, and that's why the session is fantastic, but the budgets decide the priorities. So if GC8 is fundamentally about prioritization, then we have to prioritize children and adolescent TB in the budgets. They are often invisible in the assumptions, and they're the first to be cut off. I want to leave with you 3 lessons from my experience. Program teams leave the room too early. If a child TB is not clearly costed and justified, it will not survive the cuts, even if the project logic is here. Budgets are not finance documents alone. They are program decisions expressed numerically. Program reach must drive the cuts. So I think Welile knows this from being with me. I will not start a budget review unless the program people are in that room. Every line needs to be understood from a programmatic perspective, and the ownership of the budget needs to come from the program. It's your responsibility to protect those programs and the costs that we see. So that's what I want to leave you with as we go through today. But why child adolescents TB must be prioritized? So I've put here very well-known statistics to this audience. You're well placed to see it, but I wanted to encourage you and to just emphasize how important child and adolescent TB fits with the GC8 lens. So number one, the logic of GC8 is well suited to adolescents and TB. In Southern Africa, Eastern Africa, it remains the global epicenter of TB. Children remain and continue to account for a disproportionate share of missed TB cases. Funding constraints risk widening the pediatric gap. So everything, when we see this, we need to prioritize the burden where it's high and progress is slow. And that is, as the data is showing you here, in child and adolescent TB. So the big evidence that we have, the reason where you can sit and fit this excellent discussion in, is in the pediatric TB detection gap. We know that 40 to 60% of children with TB are not diagnosed. We know that children less than 5 years have the highest mortality rate. We know that most deaths occur before diagnosis. So from a budget perspective, and from where we sit as the LFA when the budgets come, we're expecting to see pediatric TB case dissection as a main budget component. We're expecting to see those costs. We're expecting to see commodities related to case detection. In the same way, there are treatment and prevention gaps. The data tells us pediatric coverage is often less than 70%. Prevention, we also only see that 30 to 40% of the eligible child contacts receive TB. And then, of course, children under 5 are the most underserved from our TB programs. TB HIV, especially in the countries that I work within Southern African countries, across South Africa, Mozambique, Tanzania, Zambia, Zimbabwe, they all share high TB HIV co-infection and diagnostic gaps in children, and they're heavily reliant on the Global Fund. In these settings, and I'll leave it to the good doctor in the next session, we'll talk a lot about that sort of integration and how we need to see that more in the budgets. So yes, up to 30 to 35% of children deaths are HIV associated. So from a GC8 expectation, we're expecting to see more integration of HIV and rural maternal, newborn, child and adolescent health in cost-effective and life-saving. So just to give you comfort, the GC8 explicitly prioritizes TB. The guidance also emphasizes reaching the missing millions, scaling case finding and TPT, integrating service delivery, and protecting TB within the integrated guides. But children lose out. In my experience, in the budgets that I see, we have very weak assumptions for child TB interventions. We also don't see CCM representation from children, from adolescents. They are a disproportionately quieter voice. We also see limited program ownership during the costing exercises, and the result is TB activities are disproportionately cut, and yet the data is absolutely clear this needs to be a prioritized intervention. And as I said, it's competitive now. So if your voice is not in that budget, if we cannot see it, it is not prioritized. So just for those, I know a lot of us actually are very well familiar with the Global Fund budget, but it's just nice to kind of, I don't know, refresh your minds again about what the budgets look like, and how GC8 is not in a big way, like a big shift from what we've been looking at in the past. So number one, the GC8 budgets link three things: the modules and interventions. So what problem are you trying to solve? The activities, how you will actually do it, what you actually need to do it, and then the cost inputs and assumptions, how the money is going to be spent. In GC8, they are the key tools that you have to document, and I must emphasize there needs to be alignment between the first two documents, the detailed budget, that includes the non-health product components together with the health product components. The health products are captured in the health product management template, and that is very, very specific in terms of quantification needs. We'll unpack a little bit of that. And then, of course, the assumptions for HR, human resources, and then travel-related costs. So these are the key tools. You need to feel familiar with them. You need to not compartmentalize where you operate in this space. You need to get involved with this budget. So just to give you a visual of what the budget looks like, you will have a budget line, the module. In this case, we're going to be looking at you under TB diagnostics, treatment and prevention, community services. That's the module. The intervention is exactly that, child and adolescent TB. Then the description of the activities, this is where you unpack what you will be doing. This is where you talk about finding missing cases. This is where you talk about strengthening clinical reach. Cost inputs, don't be afraid. Find or work with your PR as well to find out what costs those look like, help them as they prepare these budgets, and even help them quantify what that looks like. So for child, adolescents, and TB, you do not have a separate module. You have to embed this key program under TB diagnostics, treatment and prevention, community systems, human resources for health, and then, of course, M&E systems. What I want to emphasize about the budget is if child TB is not visible in this activity or at the assumptions level, it will not survive that prioritization. So you have to make sure that you articulate it here so that it's not, how would I say this? So I love that at least I have a public health background. But a lot of people looking at the budget are finance people. So they won't understand what this activity could potentially yield in terms of impact. So make sure as you are structuring your budget, you are as clear, descriptive as possible, and you're articulating how this is going to achieve impact. So just as a quick breakdown of the three main budget commodities that you'll be looking at, commodities and procurement. You know the child and adolescent commodities that are relevant. Here, pediatric TB formulations, pediatric TPT, stool expert consumables, sample collection, infection prevention control materials. These are all the commodities we expect to see under the GC8. They need to be tied to the targets, and they need to be aligned with your treatment guidelines. So it can't be a thumb suck. You have to help those preparing the budget articulate why you need the quantities that you do need. We'll go through a quick example here, but I wanted to just share with you some of the costs that we see. And don't be surprised, even especially for PSM costs, given the geopolitical climate, we do expect procurement supply management costs, in other words, the cost of bringing the commodity to your countries, to go up. So again, more of a reason why you need to quantify this correctly, align it to your treatment guidelines. So these are the costs that we've seen, at least regionally. As an example, just to make this more practical, you will have under the budget the intervention, improved detection and treatment of child TB. So that's very clear. Everyone knows that. But under the assumptions, you need to be very clear that X amount of children will be investigated per year. This is how many you will test and screen. This is how many you expect to have TB. This is how many you expect to treat, all aligned to the goals that you have articulated in your national strategic plans. And then from that, you can support the commodities quantified. So they're all to do with the people in this room, program people. If that's not clear in the budget, they won't understand it and they will tweak things. And I've seen it several times across a lot of other countries where it's not clear why the quantity is there. If your assumptions speak to it, it's fantastic. Everyone understands why we see the quantities that they do. So again, just for costing tips when you're doing it, the quantities must align to the case finding targets. The pediatric formulations often have different unit costs. Make sure you have the right ones. Use your updated treatment guidelines. Reference them even in your in the budget. Like just here, if I can even show you. So at the end of all of this, you'll have another section that talks about comments. Go crazy there. Make sure that it's very clear so that you are on the budget. For human resources for health, this is where the costs often hide the true effort to reach a child. If it takes staff time, it needs budget space. You need to be able to articulate the contact tracing needs, the mentorship, the adolescent-friendly care that is required for reaching children with TB, and of course the difficulties in pediatric diagnosis and treatment, and giving HRH, Human Resources for Health, the capacities they need to do that. Articulate the gaps that you're currently seeing. Talk about, at least in the budgets, how investing in Human Resources for Health here will improve that reach. Again, speak to what the data tells you, how many children you are missing, how many children are not on treatment. That will give that budget the evidence and the support, in fact, the priority it deserves in that space. So again, here I've just kind of put some Human Resource for Health costs here. This is community health workers. Global Fund, of course, standardized some of these costs. If you're going beyond or more than that, you need to be in a position to strongly justify it. So as an example here, you have pediatric TB training for clinicians, mentorship visits to public health facilities, and community contact tracing. If you have a lot of Human Resources for Health for children, don't worry about consolidating that into one line. As long as in the assumptions, you can clearly explain how these interventions will, or the cadre that you are investing in or that you're asking funding for, will be reaching or addressing the gap that you've identified. You will need to clearly justify the level of effort linked to child TB outcomes. Again, as we go through this process of prioritization and competing funds. Avoid creating new posts unless you can strongly justify it. Explain or at least show how you can integrate these child, TB, adolescent skills and responsibility into existing roles as far as possible. Then the last thing, of course, is the systems and the infrastructure. So the appetite here is not what it was, but you cannot ignore the fact that they are critical enablers of successful child TB and adolescent reach and detection. You cannot ignore that. So you need to be looking at sample referral systems. How well are those being supported? This is, again, this integrated tool. Integrated data tools don't have silo, multiple, or parallel reporting systems that come up. Try and see how you can capacitate or enhance the existing tools to include child TB reporting. How are you, or do you even have adolescent-friendly spaces? Do you need that? Does it show, or do you have evidence that supports that you have children in these spaces? And then, of course, digital reporting. So here, the GC8 preference is for multiple disease and shared systems. Don't ignore your needs in these existing systems. Be able to articulate that they also need to be enhanced for child and TB reach. So again, I have some costs there. Please, they're just within the SADC region because we have or enjoy the Common Monetary Fund, but this is how we generally see some of the costs that have come out. So again, here's a good example about integrated services. How are you embedding TB screening at other clinics? Do you have tools that have TB notification? Are they on the same tools that you're using? Do you have contact management tools that capture it? So just use the same tools. Same thing here with joint supervision visits, this thing of having just TB program visits, HIV TB program managements. You will not have any approval or go ahead with that, at least even if I've received something like that. We're trying to find synergies and joint supervision visits. So some of the budget implications there, they want to see, or we definitely need to see, fewer parallel costs, stronger justification under integration and value for money. So this is what I generally see in terms of pitfalls. And sorry, I don't know how I just jumped ahead. The pitfall number one is the most beautiful funding requests, NSPs, program reviews, delicious data, epidemiological breakdowns, modeling, and then thank you very much and goodbye once the budget is done. You need to be in the room. If you're handing the budget over too early, that program validation is lost. And those who are responsible in or articulating the budgets to the Global Fund, to the country teams, to the LFA, don't have program capacity to fully articulate or link these excellent documents. Pediatric TB is then diluted. So I would encourage everyone in this process, especially when you are competing with every budget line, especially when you have increasing procurement supply management costs, stay until submission. Raise your hand up, be available to the Global Fund country teams when these activities come up. Ask the PRs to be involved and be there, just be there. The second pitfall I see is weak justification during the cuts. So when the cuts happen, the activities without evidence go first. So if, like I said, you have the interventions, if you do not have a very detailed, clear write-up about how impactful this activity is, it's gone. That needs your finesse. You understand it as program people. So to protect child TB, link the cost to the burdens, the gaps, and the outcomes, and include that in the budget so that it's very clear why anyone looking at that line knows exactly what they're cutting and the implications of it. And then the third pitfall is about poor ownership and weak linkages. It's a bit more like the first issue there, but problems we often see is even child TB is isolated. Their budgets, they sit alone. You don't see it as an inclusive part of the TB program's agenda. We don't see the links to the NSP or the target. So here, you need to explicitly link things to the TB strategic plan, the pediatric TB targets, the integrated service platforms, and and make sure they are just as visible as other high-level activities. So what survives the GC aid review? Clear prioritization, evidence-based costing, integration without invisibility, and strong program ownership. So just as a summary, stay in the budget process, know and defend your assumptions, use your integration strategically, ownership protects child and adolescent TB. Ask yourself in your country teams who's validating the child TB budget assumptions. Can you defend them when the cuts come? And where's child TB embedded? It must not be isolated. Thank you.
Thank you, Ms. Lindiwe. Full presentation. And I think we should questions and our inputs until later on after the second presentation. So now I would like to welcome our second presenter, who is our last presenter, Dr. Demelish Asefa, who will present on integrated program. Dr. Demelish has been with KNCV Tuberculosis Foundation since 2015. He is providing technical expertise to TB control programs in Ethiopia. He has also played a key role in developing evidence-based national strategic plan, WHO people-centered framework, and he specializes in epidemiological modeling, strategic planning, and cost estimation. Currently, he serves as an infectious disease modeler at KNCV TB Plus Netherlands, supporting countries with data-driven decision-making for TB. He holds a master's degree in epidemiology and in project management with over extensive experience on TB and AIDS. Over to you, Dr. Demelish.
Thank you for welcoming and brief introduction. I'll be directly go to my presentation. Please tell me if it is shared. Can you see my slide?
Yes, we can. They're
Okay.
visible.
Okay. Thank you so much. I'll be presenting with budgeting for integrated TV programs within the Global Fund context, specifically focusing on child and adolescent related activities with TB. So I'll try to address these topics. What is the purpose and scope of budgeting for integrated TB program, and why budget integration matters now? Because this is the high time to talk about integration, and also integration entry points for TB, including child and adolescent TB, and costing integrated interventions. I have some practical examples and key budgeting tips and common mistakes. We'll start with the purpose and scope of budgeting for integrated TB program. The first one is just to understand what integration means in budget terms. This is just beyond the programmatic integration concept. And the other one is to know practical approach to cost integrated TB services. And the third one is to be able to identify budget sections and co-financing opportunities with Global Fund proposals. We'll start with why budget integration matters in the current funding landscape. As you know, currently the Global Fund funding opportunities being very tight and considering the value for money, so we need to shift most of our intervention to integration manners. So when we talk mainly about integration, there are some challenges, especially faced the reviewers during Global Fund proposal reviewing. Always we talk about service delivery integration, but the budget is not really integrated. we have integrated service, but other programs, maybe 2 or 3 programs, may do the budget, duplicated budget for the same integrated program. So there is always parallel structure and duplication of staffs, duplication of supervision and the likes. So that was the main challenge. Therefore, integration means mainly sharing a platform and sharing a system. If there is existing system, now TV program would be use that existing system instead of creating or establishing a new system, like combining TV outreach service with the existing HIV program to reduce cost. We have also HIV clinic at health facility level. So with minimum additional cost, we can provide TV services with this platform, including community platforms and the likes. So we need to integrate the service as well as also the cost. So by doing this, we can ensure the sustainability and efficiency of our resources and also our programs by integrated budget, embedded TV services within broader health system, enhancing sustainability and funding resiliency. Therefore, translating integration rates for RIC into budget decision improves proposal credibility and protect core TB interventions. What are the key integration entry points for TB that we anticipate for Global Fund application? The first one is HIV. So when you say integration at HIV clinic, HIV platform are practical entry point for TB screening and preventive therapy, and also diagnosis and other follow-up activities, mainly for HIV and for children and adolescents also. And here, with sharing resources like screening platform, outreach teams, just allocating small amount of human resource budget, we can do the outreach service with the HIV team, and data system improves budget efficiency for TB and HIV instead of having parallel recurring reporting systems and others. So by only adding the incremental cost, when we say incremental cost, for example, for HIV, there is existing system which is being run to provide service for HIV people living with HIV. So by adding additional cost, minimum cost, to provide TB services, we can achieve the goal of TB, like providing job aid materials, providing minor staff budget allocation or diagnostic supplies, or also for training. Sometimes for training, instead of arranging full training for people working in HIV clinics, just adding the TB component on HIV training is we can minimize also costs. Then improving access and transparency, like integrating TB in HIV program enhance service access, cost effectiveness, and requires transparent budget documentation. So when we do this, the budget should also be transparent, which should be covered by HIV, which one from TB, and we need always ensure there is no duplication of resources or budget allocations. The other one with the integrated entry point is RMNCH, especially for children and adolescents and mothers. So this is one of the entry point to provide TB service or to embed TB screening, prevention, and other services. So integrating TB activity with existing workflow minimizes cost by avoiding separate system and workflow. Here we can TB training module, as I said, and also other MNE related activities like adding recurring, instead of having separate recurring reporting system, just adding those TB data elements or indicators into the existing RMNSH system, so we can get the data and also providing joint supportive supervisions and other MNE framework. So by doing this, we can maximize the reach of TB services with the minimum cost, just by linking child TB contact investigation with immunization and nutrition programs and enhance coverage cost effectively. The other entry point is community. So in most countries, we have a community health system, which addresses a lot of various health programs. So TB is part of it. But in terms of costing, mostly we tend to allocate budget separately for TB program, all the costs. That may be very expensive practice. Therefore, we need to embed the TB services into the community level activities, like identifying vulnerable population at community level using the existing community system and providing TB prevention, diagnostic, and treatment services. So integrating TB services with HIV and the reproductive health programs extend reach without no infrastructure, without additional infrastructures, just using the existing infrastructure. So proportional costing and shared resource improve efficiency and align with community engagement priority. This is also very important for sustainability and also to use our resources efficiently. And the other is using community platform enhances TB case detection, adherence, TB prevention, stigma reduction, and cost effectiveness. So what are the practical approaches when we do integration, budget integration, in addition to program integration? The first step should be identifying the service platform. What are the service platforms that TB program or TB activities should be integrated? So we need to determine where TB activities will be integrated, including HIV clinics and community groups. Especially additional resources required beyond existing services such as staff time, diagnostics, or other monitoring related activities. So distribute cost based on realistic assumptions like staff time spent on TB related tasks. And then we need to document all the assumptions. This is mainly very important during the review process, especially for Global Fund. So we need to clearly put the assumptions when we develop the proposal, the TB, additional TB budgets when we integrate with other services, just to avoid this overlapping or parallel budgeting system. So just some examples, costing adolescent-friendly TB services, for example. So embedding TB screening within existing adolescent health platform, enhance accessibility and efficiency. So costs are incremental, reallocating existing staff time, just add some allocation for existing staff. We don't need to hire new staff, and minimize new expenditures for TB activities. And adding TB contents to planned adolescent or HIV training reduce additional training cost effectively. As I said before, we don't need to have new full training packages. We may add these all components of TB activities into the existing training materials. But always when we think integration, we have to also think about the quality of services. We don't need to compromise the quality of TB services when we integrate with other services. And having simplified monitoring and evaluation. Adapting existing registers and reporting tools supports efficient monitoring without new system development. Similarly, for costing child TB contacts investigation through community platform. So integrated use of community health workers. Utilizing community health workers involved in various health activities improves efficiency in TB contact investigation. These community health workers are already there providing TB service, and they may go house to house or maybe at the community level. So just by adding TB specific activities, we can achieve the maximum result from this with minimum cost. And budgeting focus on allocating only the proportion of resources and time dedicated to TB contact investigation only. And TB supervision is integrated into existing health program oversight to avoid duplication and improve continuity of care. And still, we need to have transparency and documentation. Clear documentation of assumptions and shared responsibilities ensure transparency and facilitate grant implementation. So, optimizing budgets through existing investment. The other one that I want to share with you is about optimizing the existing resources. First, we need to recognize the existing investment in order to avoid duplication of resources. As we said, we are now in short of mostly with the resource, so we need to recognize or do some resource mapping activities. In most countries, especially during strategic plan, we do funding landscape analysis and we identify a funding source for interventions or for activities. We also identify funding gaps. So mainly when we do this budget proposal, we should focus on those with funding gaps instead of already invested areas. Focusing on complementary inputs, like allocating TB budget to training, quality assurance, and incremental commodities when other inputs are already funded. And use of co-financing notes and justification to clearly communicate funding sources and arrangements to reviewers, and maximizing impact and sustainability, leveraging partners and government funds, strengthening sustainably and create realistic and impactful proposal. So in this case now, if we maximize already existing resources, now we can avoid the duplication and ensure the value for money. So some good practice and common pitfalls in integrated TB budgeting. First one, key reviewers' expectations. We need to know this. Reviewers value clear costing, shared resources, documented assumptions, and alignment between narratives and budgets. This is the main key areas that we need to check when we write our proposals. And common budgeting pitfalls, which is double counting costing, misclassifying activities, and unsupported ambitious scale-ups, raising feasibility concern. So here, during strategic plan development, mostly we are ambitious, we plan ambitiously, that's good, but we need to make sure that these ambitious plans are evidence supported. At least we need to have some evidence for this ambitious plan, and also we need to defend that these interventions are feasible. And mitigating the risks. The other one is this proactively addressing concerns in budget designing reduces risk of cuts or delay during grant making. So these are the main takeaways here. So integrated service requires integrated budgets that are logical, transparent, and grounded in program realities. Over. Thank you.
Thank you so much, Dr. Demelish, for that excellent presentation. And thank you for highlighting key messages in terms of approaches to integrate TB services in HIV, RAMCAN, community services, and also the part of costing integrated interventions. And thank you also, Ms. Lindiwe, once again for the wonderful presentation and sharing in terms of costing and what actually is hidden during the child TB budgeting. So at this point in time, we will open up the discussion. If we have any questions to our two key speakers, we can raise our hands and be able to ask the questions to our presenters. Any questions to our two presenters?
I see a hand from Rita.
Okay, thank you. Rita, please go ahead.
Thanks very much to our presenters. I wanted to draw your attention, Mr. Chair, to Martina's question in the chat. She may still be with us because she says she may need to leave some 5 minutes to the full hour for the next meeting. I wonder if anyone in the meeting has any thoughts about what Martina has just said. I won't comment at this stage, but I just loved the two presentations, and particularly when Lindue said that budgets are actually program decisions expressed numerically. I haven't heard that budget definition before. I found it very impressive. Thank you.
If I can just react, and I'm very happy for everyone to do it. It's so nice to see some other Lesotho programs and Eswatini programs who are here. I really agree with her. I think she's absolutely right about needing evidence on the minimum package of additional resources you do require to allow integration of quality TB peds in the community-based and facility level. I haven't actually seen that articulated in a sort of document before, which would lend itself very well to assumptions within the budget and costing. So I think it was well articulated from her. Over.
Thank you so much, Rita and Lindiwe, for that comment. Do we have any other questions or comments for our key presenters today?
Peter says to me, how do we tackle the issue of dilution of pediatric and adolescent TB during GC8 funding request writer? That is an excellent question. And unfortunately, I'm not going to give you an answer that's straightforward. It's really about your ability to be at that table, to be listened to show the evidence, to have that articulated beautifully in a way that it cannot be ignored. I love my TB program and their ability to give me sound epidemiological data. It's impressive, and no one in the room can have or can ignore it. So I think it's about how you advocate to be in that room, your ability to present good, sound, evidence-based data, and clearly articulate that need. Welile and I had a lovely budget review where she asked for huge budget activities. The TB prevalence survey, do you remember that? And the drug resistance survey. Massive batch of dimes. Like it was the first time we'd ever seen the TB program so boldly insist on such big surveys. And Minghala, who's on the call, and Ntate Popo, they also had a TB prevalence survey in their budgets. And it was excellent because it was very clear we had no evidence about drug-resistant TB or the prevalence of Eswatini TB prevalence, and we knew we were missing cases, but we didn't know the rate at which we were or what other investments were needed. Needless to say, she fought for that program and those two budget lines during the grant making, and they remained. And to this day, they're the only two pieces of real empirical evidence we have about Eswatini, and every other response and activity is as a result of that data. So when you tackle it, like, be bold. You know, you are advocating for children who do not have a place on our boardrooms, who are not part of the budgets, and yet we are missing them. So I would empower you, Peter. You know, you have nieces, nephews, children of your own, just to be brazen. You know, this is the time that you're competing. I think niceties are out of the window. Funding is really going down. So yeah, just be a different a different person, I think, under GC8, and fight for that corner, lead with evidence, and you will garner the support you need. Over.
Thank you so much, Alindiwe, for that wonderful explanation. And as Dr. Demilesh was presenting, I was actually trying to understand. I think traditionally what we've seen when we talk of integration is that integration, we've spoken about it quite often, but it's more of a concept and not actually something which is actualized, because integration only comes into play or effect at the point of service delivery, as facilities or healthcare workers are implementing interventions. And you find that most, even as we try to integrate, priority is actually given to the program that did the budgeting and organized that intervention that they're actually implementing. So as Lidiwe and Demilesh were presenting, what was running in my mind was, with the current focus being on integration, I wanted to hear how best actually the child and adolescent TB interventions can be budgeted with these integrated platforms. Whether integration has to be done at budget level or actually at a part of service implementation. And it was good to hear that coming out, that it's really important that integration has to be done from the budgeting point as well. And I think from experience from the Zambian team, in our next NSP, which will run from 2027 to 2031, integration is one of the key messages that is coming out in the NSP, and actually in almost all the strategic interventions, integration is actually coming out, and probably to be good to also link that integration from the NSP into the Global Fund budgeting, which will make it actually easier even for the implementers in terms of the health facilities try to integrate service delivery at those tertiary lower levels. Thank you. I would maybe, just before anyone else comes in to comment, I'd want to hear maybe from any other countries their experiences in terms of practical experiences, any challenges and strategies that are related to the budgeting for integrated TB programs with the current funding landscape. Do we have any country that can share their experiences? Okay, I can't see any hands or volunteers to share their country experiences. Okay, maybe to Lindiwe, I wanted to maybe to hear from you in terms of how best the countries can actually, as we know that with this current funding landscape, with some form of reduction in some parts of funding, and the need for also local governments to see how best to increase their domestic financing, and for some of the the intervention. I don't know, maybe from your experience, Lindy, how best can countries tackle this combination of the Global Fund budgeting and also trying to leverage also on some of the domestic funds from within the countries. Maybe your experience from your interaction with other countries across the region.
Well, I think I'm very biased because I work with the excellent namesake Lindiwe, who is also part of the Eswatini TB program. And I've seen how she has led the TV program. And it's what I said, it's what you guys are fully equipped with, data and evidence. And so what I've seen is she, when the funding went down, when the US government secession happened, they did an excellent analysis on where they were most vulnerable and presented it first to the government. So they went to the senior management team, PSO Health, and articulated where they were most vulnerable. And then looked at where life-saving interventions would be and protected that with data. What was the data saying they both needed? And it was TB detection, coverage. But what I was so impressed with, I think it's in the recent review we saw, 42% of every TB case came from a TB champion under the TB program. In providing that evidence, she made a very strong point that you cannot, even with dwindling funding, remove this essential cadre. Whether it's a parallel system or not, this is how we find TB cases. And then diversifying that to childhood TB cases. We haven't seen that come out so strongly, so no pressure, I didn't do it, but it would be good to see. She's used the evidence and she's in the room. She's talking to everyone. She is sharing information with the Global Fund. She's sharing it with us. And making it very clear these are the consequences of what will happen if not. And they've made excellent strides in integrating their TB system within our centralized management information system. So in parallel, not only is she making their own steps or putting the TB program into these integrated spaces, she is using the evidence to motivate all of us to open up our eyes, even pockets, to support these core services. It's a long answer, but I only have that as a very good example of good leadership, good use of data, and advocacy. I hope that answers the question. Over.
Yes, thank you so much, Linda, for sharing that wonderful experience. I've seen a hand from Alan. Alan, over to you.
Yeah, thank you very much, John. Can you hear me?
Yes, we can hear you perfectly.
Yeah, so I just want to share some little experience from Tanzania as far as the Global Fund Cycle 8 is concerned. We are currently in the writing process. We are expected to submit window 1. The biggest challenge I've seen in terms of integration of the TB services, especially child and adolescent TB services into the funding request, is that the allocation for the country like Tanzania, the TB is only 7% of the total allocation which is coming in the Tanzania, and out of that allocation, 80% goes to the commodity, while the remaining is 20% for the programmatic activity. And that programmatic activities, you find that the diagnosis, treatment, and care take almost more than 70%. So the small chunk remain for the other modules like KDP, which is under which in that particular category we have adolescent and child, and the allocation is very, very small. So that is the biggest challenge that to sustain the childhood TB services through the Global Fund. However, the country plans to use this opportunity through Global Fund Cycle 80 to mobilize resources to local government authorities to integrate the TB child and adolescent TB services into the primary health care system. including the issue of the screening, diagnosis into a routine primary health care system. So we think from that perspective, this adoption will help us to make the TB services as a part of the primary health care services. In that aspect, it will be easier for us to also monitor and support locally the intervention related to TB in children. So that is the experience from Tanzania we are looking for. So for financing through other mechanisms like PPP, public-private partnership, making the private sector to contribute to the national efforts to end TB through multi-sectorial accountability framework for TB response, which also take into consideration the resources from the other sectors. So we are trying to push, but really it's a challenge in this particular point, especially with the little allocation from the Global Fund. That is what I can share from Tanzania. Thank you. Back to you.
Thank you so much, Alan, for sharing that wonderful experience in terms of how to integrate childhood TB in other services within the country. And we appreciate that experience. I have seen, just before I hand over to Rita, I've seen some questions and comments in the chat box, and probably we can just quickly tackle before we wrap it up. And there's one for Damelish. So if I may recall this, I apologize, I can't see the names, but I'm thinking it came from Peter. Yes. So if I may recall, in the modular GC8 framework for childhood TB, which is under module 4 for KVP, there is no intervention for children and adolescents about RAMCA. So how do we integrate with it without that activity being rejected, since it is not listed there? That's the question that's for question for Demilish from Peter. And there's also another question or a comment in addition to Dr. Kachuka's comment. What specifics should we consider in integration, as we have seen a less focus or overcrowding of adult TB activities during implementation? So what should we consider in integration, as we may have seen less focus or overcrowding of adult TB activities during implementation? So, Demelish, if you can just quickly respond to those two questions, and over to you.
Okay, thank you. I think maybe in terms of integrating childhood TB into RMNSH, maybe we cannot find directly the integration on the Global Fund module, but still, if we have strong evidence with the RMNS service, which is already existing service, and if we maybe justify well, still we can maybe add on this area, since the main document of the Global Fund also talks about the integration of childhood TB with RMNSH. So if you have any local evidence with integrating this service can benefit the TB program, I think still there is a room to add on this module. Yeah. Over.
Thank you so much, Demelish, for that feedback. So unless there's really burning question or comment, otherwise before we close, do we have any burning comment or question from anyone on the call? Okay. Thank you. So today's discussion has really reinforced that integration is not simply about combining services, but about improving efficiency, sustainability, and impact. And it has to start from planning, budgeting, before we can actually integrate the services. So as the countries prepare for funding requests with constrained environments, strategic prioritization and leveraging existing systems will be essential to protecting child and adolescent TB investments. So thank you so much to the two presenters, Lindiwe and Demelesh, and thank you so much to all the participants for your comments and questions. I'll hand it over to Rita for our closing remarks. Over to you, Rita.
Thank you very much, Mr. Chair. And please allow me not to switch on my video due to very unstable connection this afternoon. So I echo your gratitude, Alan, and want to say once more thank you to our presenters and to you and Peter for facilitating this discussion. I also wish to thank all participants for a rich and practical discussion. There were perhaps some points that have remained unanswered. We have modes of continued discussion, for example, through our WhatsApp group. The insights shared today highlight the importance of early engagement, integration, and strong advocacy and staying on in the process until the very end to ensure that children and adolescents remain central to TB investments under our Global Fund funding proposals. Let's also remember that every $1 invested in TB services brings in a return and benefits worth $46 US. Our COE remains committed to supporting countries as you navigate the ground cycle aid processes and strengthen your TB responses, and we look forward to continued learning and collaboration with you. Thank you all for your active participation, and bye.
Thank you, everyone. Take care. All the best. Bye.
Bye-bye.
Thank you. Bye.
Bye-bye.
Thank you. Bye.
Thank you, everybody. Bye.